Just maybe a 30-second intro of each of our guests and who you are and where you work. Any order.
Sure. I'm John Kazianis, Vice President, Medical Director with High Acuity Health. I've been in the telehealth space for over 8 years.
I'm Dave Worthy. I'm a CMO at Baptist Health Corbin and also Vice President of Medical Affairs across Baptist Health System in Kentucky.
Chira Zude, I'm the Medical Director of the Cleveland Clinic eHospital, which is our ICU telemedicine, and the Medical Director of ICU operations for the clinic.
I'm John Berkowitz. I'm an ED and EMS physician. I'm the Medical Director for Emergency Telehealth, EMS, and Transfer at Northwell Health.
I'm Corey Scurlock. I'm the CEO of Equum Medical.
I don't know. Doesn't sound like it's on.
Yeah. How about now? Can people hear me?
Yes.
Better. Okay. I'm Corey Scurlock. I'm the CEO of Equum Medical. I'm a critical care physician. I've been involved in telemedicine for about 12 years, and I run a company called Equum that is an acute care telehealth company. So,
Thanks. Glad to have you all here. As we look at celebrating the 30 years of ATA and 25 years of telecritical care, what I'd like to do is start out with some reflections about where we've come from and then what aspects we'd like to take forward. And when I think of it from the nursing perspective, I look at how we're now telementoring and teleprecepting nurses who are so new and so inexperienced and need that support. And I think of the awesome advances we've made in recognizing and surveilling for patient deterioration. And I also think about the many advances that are to come. And so what I'd like to do first is start with Dr. Kazianis and Dr. Scurlock to kind of reflect on where we've been for 25 years, and then maybe the rest of the panel can talk about the aspects of that we would like to take forward into the future.
sure. So, we're on the 25th anniversary of the first tele-ICU. Dr. Rosenfeld and Dr. Breslow came up with the idea at Hopkins in 1998. At the time, I think truly visionary. During that period, we have seen a lot of advancement. I think now we certainly face the challenges of manpower. And it's now 20 years since the Compact study came out. And so to me, we're at the middle of the beginning of the manpower shortage.
Yeah, absolutely. I mean, from our perspective, it's been really fascinating to see the field evolve. 20 years ago, the use case for tele-ICUs were somewhat limited to smaller rural hospitals. And now with, through our experience, we've seen that use case change dramatically. Now even, hospitals that have 24/7 in-house intensivist coverage are leaning on the tele-ICU model to address some of those workforce shortages that you were talking about. And of course, it's permeated into even the academic medical center space as well, where there's a lot of staffing. So I think one of the fascinating things for me is to see how there's really a use case for any type of bedside staffing model that you can incorporate into the tele-ICU.
Absolutely. Dr. Uday and Dr. Worthy, when you think about the aspects of where we've come from with telecritical care, what would you like to see going forward into the future?
If you think about when we started this, information and data acquisition was really difficult. A lot of, if not every hospital, was still chatting on paper, right? And devices, if you had them, for monitoring patients or providing care, did not have any way to output their information into any other system. They were pretty much closed boxes, right? And so in 25 years now, practically every hospital's got some EMR. First generation, it's clunky, but it's there. And devices now can output their information into EMRs or into some other hub, right? New devices are coming out. And so in 25 years, we've gone from really archaic in terms of data acquisition and data entry to, I don't want to say state of the art, but now this stuff is in an electronic format. And with that, we can do a whole lot more. So big change in over 25 years. And I think that there's more of that to come.
I absolutely love that. What do you think, Dr. Worthy?
We came into this space as someone trying to solve a problem. I work at a small community hospital in southeastern Kentucky. We had one pulmonary critical care doctor. We have an open ICU. And I didn't have anybody to take care of my patients at night or the weekends. And so that's how we got involved in this. That was about 6 years ago. What I have come to understand about this is really, not only did we not lose quality, I actually think we gain quality by partnering. And one of the things that I've learned is I think where the space is right now and what we've proven, and probably John has some more data about this, and so do others, but really there's actually an improvement with care if you do it remotely. We can offload the cognitive portion of ICU care safely, effectively, and efficiently. And I think we're right there right now. I think that's the space we're in. You're asking about the future and where I'd like to see it go. I can't imagine the data files that these guys have in terms of the 100 plus ICUs. Just think about the clinical gems inside that data and applying some AI techniques to that to learn what we don't even know. I'm sure there's correlations clinically about things, BMI and ventilation settings and all those things that we kind of have an idea about, but if you actually parse the data and looked at that and put some AI around it, it would tell us even better, most effective care. And that's the other thing, the other surprise to me in working with Acuity in this case is they made us better because they've been able to show us benchmark data from their other partners. So now I know where I am in terms of the rest of the universe. So how much better will that get when there's AI around that? And I do think there's, in addition to that, there's a serious workforce problem in rural America. I think it's all over the US. And I think, and maybe we'll get into this in a little bit, but I think there's a real opportunity for that to be solved, working remotely and doing the cognitive portion of medicine in the ICU and maybe other places, in fact, definitely other places in the hospital. And that frees up to really develop your workforce in other ways.
When you mention the cognitive load, I think about the novice nurses coming into ICU and the cognitive overload that they are undergoing in such a way that they can't even focus on one or two tasks at a time. They are so task focused. And I think using telecritical care has been such instrumental in helping those new nurses get to a place where they can take care of those patients and overcome their cognitive load, because the cognitive load contributes to their burnout. So I'm glad you mentioned that, because that's a really important piece, I think. Dr. Berkowitz, I'd like to hear some about your work with tele-EMS and tele-emergency medicine and some of the things that you've been able to accomplish and where that might go in the future.
Yeah, hopefully it's actually going to reduce the amount of patients that go to the ICU. We've had a lot of cases that we've seen patients in their home. They call us and they say, I don't know if I need to go to the ER. And we've been able to do blood work at home, determine, I had one patient, she had a head bleed. She thought she had food poisoning. And I figured it out when she had massive photophobia. She would refuse to get on camera with me. And I said, well, that's not food poisoning. But I know that. Exactly. So I think that we're going to, and we've had a lot of cases where we've actually had a meaningful impact on the patients by catching them early, because they didn't think they need to go to the hospital. And I think one of the things that contributes to long length of stays in the ICU, which then leads to the workforce issue, is patients having delayed presentations. So the ability to deliver care at home and to get an early look at the patient is an opportunity to impact the workforce downstream.
Absolutely. Dr. Uday, did you have something you'd like to add?
Yeah, I was going to say, and the corollary to that is when they do come into hospital, they're probably sicker, right? I don't know about your hospital, but my hospital is becoming an ICU. Every one of my hospital, not just the four walls of the ICU, but the patients who are coming in today are sicker. All the easy ones have been taken care of at home, or they're having their surgeries in an ambulatory surgery center and they go home in 12 hours or 24 hours. So if you're staying in the hospital, chances are you're sick. And so my tele-ICU now takes care of patients in the step-down unit, in the ED, in addition to the regular ICU, because the folks out there are just so sick, and I really don't have space in my 12 or 14-bed ICU to accommodate them. So the workforce challenges we're facing, now you have nurses on the floor or hospitalists on the floor or MPs on the floor who are not used to that severity of illness or to that degree, that quantity. The workforce challenges go beyond, I can find doctors and nurses. We're challenging the existing workforce with a higher acuity of illness. And guess what? I think I was reading somewhere from 2010, 10,000 baby boomers retiring or reaching retirement age every day since 2010 in the US. So Some of those baby boomers are doctors and nurses and respiratory therapists and pharmacists. So the only way we can keep them working, or one way we can keep them working, is by leveraging their experience through telemedicine, right? And having them be able to still contribute to the care of patients even though they may no longer be at the bedside. So I think that's the future we're looking at, that it's this entire spectrum, not just in the ICU, but whether it's on the floor or in the ED, these patients are sicker and we need to have people take care of them.
I think you all bring a unique challenge or a unique perspective on this challenge of workforce shortage. So I'd like to just let each one of you address it, because I think you all have different ideas from your perspective and your lens. So Dr. Scurlock, would you like to start?
Yeah, no, I think it's one of the big drivers of the current market. And so if you look, 50% of U.S. hospitals are underwater financially. That's largely driven by labor costs and higher lengths of stay, to your point about acuity rising. If you think it's not just my opinion on this, if you look at the American College of Healthcare Executives, they just put out their annual survey in which they surveyed 1,300 hospital CEOs. The number one concern, workforce. Last year, the same concern. For the previous 16 years they've done the survey, it's always been financials. Now, those are always integrated, workforce and financials, but this is the dominant concern of the modern healthcare system. If I think about how you can use tele-ICU to augment your workforce, you really have to look at the history of tele-ICU, back to your original question. So, I sort of put telehealth and not just tele-ICU in 4 big segments. There was the pre-COVID era, in which telehealth was growing at about a 300% annual rate. Then you had the injection of COVID, which forced hospitals to make quick decisions. A lot of money was injected into the system, a lot of single venue services, a lot of solving my problem in the moment, but not really integrated telehealth platforms. I think now we're in this sort of emerging state coming out of COVID, in which now hospitals are looking to sort of get value out of their purchase they made during COVID. So now there's workflow redesign and using the tele-ICU in new and imaginative ways, in the ER or in the transfer center. And then I think where we'll eventually go is this integrated evolve model, in which hospital systems will look for enterprise-wide solutions that can solve multiple problems along the pain point of ICU, ER, med-surg, post-acute. And they'll look for platforms that are modular, scalable, and flexible so that they can solve their problems for the long term. And they'll look for partners who are invested in a common solution with them.
So, I look at this a little differently when it comes to workforce, because I think there's another side to this coin, which is the side of capacity, right? Part of the reason why there's a workforce issue is because you have inefficient throughput and you have capacity issues. So just to take a really extreme example from COVID, during the first wave of COVID, they brought us up a hospital on a boat, they opened up a convention center, but within our health system, we found more places for patients than any of those other alternatives. And all the emergency managers, they had these crazy plans, building tents and all these things, but in the end, just by leveraging our health system, we're able to find a lot more space for the patients. And I think that there's a lot of work that we can do to improve how we optimize health system delivery, which will actually reduce the workforce needs. That's why I work really closely with Iris and my team at our team at Northwell to really merge transfer and telehealth and patient movement, because we believe that telehealth needs to have a seat at the table when it comes to healthcare operations to really optimize care delivery, and that's going to reduce the needs on the workforce, and that's another side of this equation. It may not, it's certainly in rural areas. I think that that doesn't work, but in our market. There's a lot we can do by just optimizing healthcare.
Cool. Dr. Worthy?
Yeah, I think if you believe my assumption that the cognitive portion of medicine can be done equally well remotely, what does that mean? Where we're struggling is workforce. So we're struggling to find pulmonary critical care docs. They're absolutely allergic right now to working more than 1 week on, 1 week off. And so that's half your workforce right there. We're having a hard time with nurses, particularly lead nurses, doing the critical thinking aspect of that. So how do we leverage our partners to train those folks? I mean, why do I need a critical care pulmonary doc in my ICU if I can do the cognitive work without that? What I need is I need a proceduralist is what I need. And that can be a nurse practitioner or a PA. They certainly are, there's models where that's already happening right now, where they're doing the intubation, the central lines, the art lines. What about a diagnostic, a therapeutic bronch to get rid of a mucus plug? Why can't an RT do that? And in fact, why can't one of these guys kind of be looking at that through the scope while they're doing that? And I think there's potential to really address and change the workforce problem if we just flip the paradigm and realize, hey, really we can do the cognitive part as well remotely. Now, how do we start, using that? Things we've talked about. What about a simulation lab where you came in and you were, as our partners, you were training our workforce to be great critical care lead nurses? What does that look like? What does that mean? A lot of that can be standardized. Some of that's going to be, specific to your institution, but most of that can probably be done. And also, you have a provider that's at 100 different hospitals. They can cull best practices, change that, help everybody's boat rise. So I see that in the future, and same thing with really developing proceduralists. And we're just talking about the ICU, but I can't find a GI doc. I've been looking for one for 4.5 years. Why in the world does it take a physician to do a screening, colonoscopy? Why can't a technician do that with the physician coming in to visualize specific portions of that if something's abnormal? So I think if you start thinking about this and rolling it forward, there's a real chance to disrupt the whole paradigm of how we work. And I think, again, if you believe my assumption, what we found is that there's no drop-off in the care. In fact, there's improvement because of some of the benchmarking and visualization. Then you got a chance to really disrupt what we're doing.
I love how you're talking about it being disruptive, and what I hear you say is that you're talking more about almost a team-based approach with more collaboration and people working at the top of their license, which is really important, and I think something that we can look to in the future. What's old is new again. Those of us in the room, older and old as me, remember team-based nursing and remember how it worked really well. And I think when we get the whole team of providers, advanced practice providers, technicians, and everyone on board in doing this work, it'll be a better place. Go ahead, Dr. Kazianis.
I would say when you're looking at the labor shortage, it's probably the nurses where hospitals and health systems are feeling this the most. Mm-hmm. And when it comes to tele-ICU, I think all of us would agree that the bedside nurse is arguably the biggest beneficiary of having that resource. So, it's 2 a.m. and in healthcare, we unfortunately, we eat our young. We put our youngest, least experienced people at the bedside at 2 a.m. and it's usually some, younger, inexperienced nurse. When they have a tele-intensivist and an experienced tele-ICU nurse to talk to bounce ideas off of, or in the case of an intensivist, to give them a stat order for Haldol for a hyperactively delirious patient, that goes a long way towards retaining that nurse and allowing them to continue to grow and learn and become, even more valuable. And it's certainly a very powerful recruitment tool when you're looking to recruit new nurses or other, hospitalists even, to be able to have that sort of tele-intensivist, tele-ICU resource. So I think everybody would agree that that's just, one of the ways in which we can address the labor problems.
That's really, really good. I appreciate all of that. Anyone have anything else on that topic?
I was going to say, I want to build on your point about team-based care. Healthcare today is really delivered as a team, right? Whether you know it or not. And I think these tools that we've developed in telehealth and in the ICU can only be leveraged to increase that. So if you grow your team of providers and fill that team to some extent with people with lesser training or lesser skills, so to speak, so that you can then scale up and cover more patients, you can facilitate the delivery of care to most people. Because things that are technical procedures can be taught to most people. And thanks to tech, today now we have tools that enable us to do that better. When I was in training, I never saw an ultrasound in the ICU. Right now, I have one in my pocket. So it's easier to place a central line. I've seen a device come on the market with a wearable ultrasound patch that I can use to monitor volume responsiveness. Name it. There are all sorts of tools and sensors that are becoming portable, modular, and easier, and if you want, idiot-proof, so to speak. So I can depend on someone who doesn't have my level of training to apply that and get me the data that I need to make a cognitive decision about a patient. I don't have to be at the bedside to do that. And so being able to use all these tools to get data so that I can feed back my analysis or my recommendations to my team, wherever they may be, is to me the magic of telemedicine. Because then I can be wherever I am and not just taking care of 10 patients in my ICU, but 100 patients spread out across the country. That's really the magic. But beyond that, the cognitive work is the same cognitive work I do at the bedside. I'm just now able to distribute that and across a wider range of patients and geography.
Go ahead.
Can I look up to that? Yeah.
Sure.
So, I mean, both the comments you guys made, I think, were very helpful. I think one of the things I always think of, in terms of capacity is, we don't really need to have more beds. Instead, we need to invest in our people and our processes. And telehealth is just an enabler of us doing that. The other thing I think about when you think about capacity management, telehealth really can augment that, whether that's in the ER, pulling the patient up out of the ER as quickly as possible or out of the transfer center, then shortening their lengths of stay in the ICU, which is often a bottleneck, or really in the med-surg world, trying to get them discharged faster and earlier in the day, which then unloads the ICU so you can move patients through it quickly. There's an immense ROI if you attack patient flow that way, and telehealth's a great way to do it, and you can do it across all the venues at once, really. So.
Just to tag on to that, I know from our data that a large portion of patients we move in our health system don't really need to have been moved. And all that movement is work on the nursing, is work on everyone, is also leads to inefficiencies where you have units that now are being kind of overburdened and units that are being underutilized. We find ways of trying to really, right size and optimize. And back to the collaborative component, in our system, whenever a patient's actually being transferred out of an ICU that's covered by ESU, the doc who's covering ESU is automatically notified. No one has to do it. It's part of the process. It's an automation, hits their schedule, they get tagged, they get notified, so that they can make sure it's appropriate, they can optimize the patient, and that, because this is now a team-based, and they are part of the team for that patient, even though, many of us know that at 11 at night, the person trying to transfer the patient isn't the ICU. It's maybe a specialist who decided to round at 10 at night. But having that team work together, it leads to a lot of value for the system.
Absolutely. Dr. Worthy, you mentioned some things about workforce shortages in the rural health system. What other challenges do you see, and how do you see overcoming them in the future?
Yeah, I mean, if you look at the data right now, you're right that over 50% of hospitals are going to be in the red this fiscal year. But the other one that's frightening to me is there's 600 hospitals in the U.S. that are all in the rural areas that are at risk or going to close in the next 18 months. And, we feel that we've had two smaller hospitals. I'm 273 bed, but we've had two small hospitals around us close. And, my primary service area went from 125,000 to 220,000 very, very quickly. And so, the challenges of having a facility to provide that care and then trying to find physicians that are willing to come to rural America to do that. And then third, the cost challenge, which we've kind of touched on, but most of rural America is very dependent on CMS, whether that's Medicaid or Medicare. And now with the MA plans coming in, every time I put an MA patient into my hospital, I'm pretty much guaranteed to lose between $3,000 and $4,000. Well, that's a great financial plan to keep me viable. So we really got to look at using all these tools, telemedicine, getting people working at the top of the line. We've got to improve the quality, and here's the key, decrease the cost structure. And so I think some of the things we've talked about relying on different ways of training people, relying on different models of care, where maybe I don't have 7 hospitalists, maybe I have 3, and then I have some remote monitoring of a couple of APCs. Instead of 1 APC, I have 4 APCs. I think that's going to play a game in all this. And I think, I think we're going to be forced to, every hospital in the land will be forced to change our model of care strictly to make the cost structure that's being basically, I don't want to say forced upon us, but put into our laps by the MA plans.
Anyone else want to go on that thread?
Adjacent to that, I was going to, again, I keep coming back to data, right?
Yep.
To perform cognitive work, I need information, especially if I'm not at the bedside. And so I think all of us, it behooves all of us to continue to demand of the EMR companies or encourage new people, new entrants to come into that market, right? To design EMRs that serve us rather than us being slaves to the EMRs. Right? You hear all the stories about people spending hours just documenting and click fatigue and all of that stuff. That is time that I could be seeing another patient. So talking about workforce shortages, I think if we had optimized processes for acquiring data, recording data, and sharing data, we may not have any workforce shortage because we spend so much of our time doing administrative work. Administrative in the sense that we're just entering data and retrieving data and sending data across. It's important, we need that. If I don't have the data, I can't make a decision. If I don't have the data, I can't do research. If I don't have the data, I can't send it to you somewhere else and ask for your opinion. I'll end up having to send a patient to you. So how do we ask and insist as a society, as practitioners, that you come up with a new device, great, it's whatever it is that you want it to do, can I apply it easily? Can it get the information from me, send it to the hub, and not wall it off so that Joe can get it and Peter from the other company can get it? Let's demand that stop. And if your device doesn't do that, well then move over so next guy comes. Because you can't do cognitive work without information. The ability for us to do telemedicine, telecritical care, depends on us getting all those streams of data. So monitors and sensors at the patient level that are easy to use, that a layperson can apply, and will give me the information and send it to where I need it, is really what we need to demand of our vendors. And same thing with the EMRs. Can I put in information without clicking 50 times to write a 2-sentence line? Can I find this patient's lab result without clicking 20 different screens? All that takes finite amount of time, and the more you add it up, the less time I have to attend to the next patient.
I think everybody feels your pain on that one. There's no, everybody's like, yep, absolutely. I have a question for all of you, and it's one that's come to me as I've been listening to you and listening in the conference, is that we're trying to identify, keep identifying the outcomes and the data and the value. And so what are in the future the key performance indicators that are going to really establish that the acute and critical care virtual space is successful? Anybody?
I'll go first. So, the last 20 years, we've seen a lot of mergers and acquisitions in healthcare. And just like most mergers and acquisitions, the value just really hasn't been achieved that we thought it would be there. A large component of that is really around, patient flow. And, what we see is the motherships are all overloaded, sometimes with lower acuity patients than they want, driving down their CMI, driving down their financial pressures. And then the community hospitals, the spokes, are all underloaded. And so using telehealth to reorder that and then getting data out of it so that the right patient gets the right care at the right place at the right time is really powerful. And we can also augment that with risk-adjusted data looking at mortality and lengths of stay. And we've certainly found some studies now recently that seem to correlate with that. But I think, impacting how the patient moves around the healthcare system can have both outcome benefits but also financial benefits for healthcare systems. And it's a great use of telehealth on top of that.
Yeah, I'll follow that because, from my perspective, just the whole movement part, that's what I live for. A really good example of a KPI is several that we've seen when we integrated our telestroke program with our transfer center. It was a standalone program. We integrated it within our transfer center, and so what ended up happening is we had an increased utilization, which is great, but more importantly, we had a drop in the door and door out time, which is fantastic, and more patients are staying within our system to talk about that downstream impact for their care. And then we measure satisfaction from our docs who use our services, and their satisfaction has skyrocketed. So those are some of the things. I do think that I'm a big fan Anyone who knows me, I love sending surveys. So we have tons of automated surveys from my call center. And I think that one thing that should always be measured is provider satisfaction, because that tells you more than a lot of other, it's subjective, but it tells you so much more than you think it does.
Absolutely.
I would add, I don't think there's a one-size-fits-all answer or solution. I think every hospital or health system is different and has different goals. Adding to what Dr. Uday said about sort of our EHR, EMR vendors, I think we need to look for more customization in some of our technology solutions to address the specific goals for a given hospital or health system. The KPIs are going to be different depending on the maturity of your ICU or your health system. So I think customization moving forward is key, and flexibility is key.
So I'll take a shot at this. For me, it's actually pretty simple. It's the value-based equation. So for me, that's quality divided by cost times patient experience. What can you do to improve all those? So let's talk about value, or let's talk about quality. Really, can you bring a more rapid, more accurate diagnosis to my patient and decrease the mortality and decrease the complications while you're doing that? If you can do that, you got me on quality. Now, there's a lot of KPIs that go into that, but that's what I'm looking for. So let's divide that by cost. Can you do that at a lower cost base? Can you figure out how to help me with my workforce to have a lower cost there, to have more appropriate use of antibiotics and have a good antibiotic stewardship program, to only do imaging when it's necessary, only order testing? So now you've improved my quality, you've lowered my cost. That's the things I'm going to measure. And the big one for cost, by the way, is efficiency. Can you lower my length of stay in the ICU, which is my most expensive bed in the hospital? And then the patient engagement's a tricky one. Remotely, I think every telehealth company is kind of scheduling on, or trying to figure this one out, right? How do you have a really meaningful engagement with the patient in a remote manner? I'm not sure I know the answer to that, but if I have those three things, a partner or a program that has helped me to improve the quality, lower the costs, and adequately engage my patient, particularly not only in the hospital, but if we can figure this out through the continuum of care to the next handoff, that's the partner I want. I think that's what I'm looking for from telemedicine or any partner, really.
In our SIG meeting earlier, someone brought up that the patient's experience in the Press-Ganey scores is not reflective of telecritical care because they don't even know they had that. And so how do you overcome that? Is it from the family's perspective? Just throwing this out as a thought for anyone to think about, but how do you overcome that and finding that value there? The other thing that I would add is that from AACN, we are very much invested in the healthy work environment and what the healthy work environment can bring to the patient experience and the clinician experience and improving that. And I'm wondering what any of you have an opinion on around improving the health of the work environment going forward for acute and critical care. Go ahead.
Yeah, I'll go first again. So I'll go back to the ER example. So when patients are waiting for an ICU bed in the ER, we know from the medical literature that every hour they wait, there's a proportional increase in length of stay and mortality. There is also a workforce problem there too, because the ER team isn't really invested in that part of their care. They have actually admitted them, and they don't view that they're part of the care plan anymore. So using a tele-ICU team, nurses and doctors, to go into the ER, start taking care of those patients, get best practices enacted, get goal-directed therapy started, help meet with the family, but also unload the frontline worker. That's a critically important part. That can allow the ER team to go do all the great things that they need to go do and not focus on that critically ill patient. So I think being imaginative like that, using tele-ICU in different ways that people haven't thought of is often very helpful on multiple venues.
Sure. I'll just keep taking it from you. Thank you.
We used to work together.
I know, yeah, exactly.
It shows.
So we have a freestanding ER, and anytime they admit a patient, they have to be transferred. And anytime they have a sick patient, we try to get the ICU involved. to help mitigate that, because honestly, as a freestanding ER, they're not used to that. So I'm going to kind of echo what Corey said. Really, by providing that expertise, really does make a big difference. As an ER doctor, there's a lot of stress to the staff, and the ability to have someone the patients keep on coming in, and the staffing ratios don't change. So it's a real opportunity to provide value to emergency rooms when the ICU can help out an ER, both on the physician side and just as important on the nursing side, to keep that going on. I also think there's some interesting opportunities, using other technologies, like the sitter programs and other things like that can hopefully lead to reduced danger to our staff. I do think that a lot of our staff live in fear of certain patients. Personally, I popped an umbilical hernia trying to manage a challenging autistic patient. I do think that there is some opportunity there, and anything we can do to protect our staff is super important. I mean, that's why a lot of hospitals, including our own, have metal detectors. They're not the panacea, but it's just important to make people feel that they're safe. And I think there is a role for telemedicine in that.
Absolutely. Dr. Uday?
A couple of points. I think I mentioned when I was speaking earlier that my tele-ICU now routinely takes care of patients in the ED. Routinely because we have borders coming up more and more frequently. The hospitals are full. And so, I mean, at the end of the day, if you think about it, telemedicine in any fashion, whether it's teleneurology or telestroke or tele-ICU or tele-primary care, is just a tool to get care to the patient faster. And if you can do that, good things happen. Your length of stay gets shorter. Hopefully they get better clinical outcomes because you're preventing deterioration. You're getting the antibiotics started sooner. The downstream effects of all of that is the ability to get care to the person faster. That's the magic. And with the technologies we now have, I can do it not just for one person, but hopefully for hundreds of patients. And so that's the magic. There's no magic to telemedicine itself other than it speeds up that effector arm for getting care to the patient. So if we can do those things effectively and hopefully deliver the proper care to the patient, that's where the patient satisfaction is going to come from, right? If you've ever had surgery and had a biopsy done, you probably have never met your pathologist. You probably never will. You only get to find out if the pathology reading was wrong, right?
Yeah.
And so the patient's overall experience really is, did I get into the hospital and come out alive and come out healthier without complications? If all of that happens, how the hospital did that magic, it's almost irrelevant, right? And so, yes, I agree, it's good to put the word out there that telecritical care is happening, if only to increase awareness for everyone, but also to help support the resources that need to go into it. But I don't see the need to do that in itself for itself, because if I do my job well, my primary specialty is anesthesiology. If I do my job well, the patient shouldn't know that I exist, right? They have their surgery and they go away. So that's the way I look at telecritical care. It's just a modality to help us speed up the delivery of care. And with the technologies we have, we can do it for more people. If we can do that well and consistently and keep looking for use cases, where are we seeing bottlenecks? Is it in the ED? Is it in the step-down unit so I can get my patients moving out of the ICU? Well, then I'm going to go support that. If it's on the floor, wherever it is, let's just leverage those technologies and move the patients along.
Absolutely. Yep.
So you ask how will it, I'll tell you how it has.
Yeah.
Before I came here, I queried some of our nurses in the ICU, and they were wondering if I was thinking of getting rid of it, and they said, we will duct tape you and roll you off the roof if you think about doing that. And they looked very serious.
They were, as an ICU nurse.
And so the reason is because we've already helped the health of the workforce. So a nurse, particularly during a pandemic, but even at other times with a critical care patient that doesn't feel like they're waking up a doctor in the middle of the night, but they can call anytime they need to, calls much more frequently. Our data is a couple thousand times a quarter.
Wow.
We're calling the partners, and much less fear, much less hesitation. They've got different structures, nurses that they can talk to and translate that into APC. So it's already helped my nurses feel much more comfortable during the day taking care of critical care patients. The second thing is my doctor's sleeping. So, you know, we to figure out our pulmonary critical care shortage during the pandemic, we actually had to go to the big city in Kentucky, in Louisville, and purchase services from a 14-person group up there. And they came down and they were really like, ICU, I don't know about this thing. You know, now they would duct tape me and roll me off the other side of the room. So I think what you're doing is you're preserving you're giving your nurses a feeling that they got your back, and there's no hesitation to call, and I think that's very helpful. I think we're going to extend the physician longevity, because I think sleep is, as all the studies show, pretty doggone important thing. And then we can say that to our patients. We can say to them, hey, we don't have any drop-off at night. We have, you know, ICU care at the same level, 365, 24 hours. We didn't have that. And so I think across the, you know, the compendium of patients to our workforce, we've already done that. Now, you know, how might we do that better in the future? Some of the things I was talking about earlier, about doing some simulation labs and really improving the skill set, you know, of the nurses. I think that's key. About maybe doing some simulation with you know, APCs around doing the proceduralist kind of thing. So I think that's all going to be healthy for the workforce too. But my answer would be it's already there. That backup is incredibly important.
I love that example. Dr. Kazianis, do you have anything on this before we go to the audience?
You know, I'll just expand briefly on
Sure.
what's already been discussed, and I think it's the general theme is that, you know, critical care is not defined by geography anymore, like the way it
Right.
used to be. So our field has to be able to address all of the issues that occur for critically ill patients, you know, in the hospital, on the floors, in the ER. And so, again, I think that's where that flexibility and utilization of you know, that type of service will be very helpful. But definitely, it's not defined by geography like it used to be.
Absolutely. What we'd like to do now is open it up for questions from the audience, and I see one in the back. I can barely see you because of the lights, but I can see you.
Thank you for the presentation. 2 questions. What's the training that goes into the physicians or the nurses that are doing these things, or to the NPs that goes into starting a program like this? Is it simulation or standardized patients? And then my second is, how do you get physician buy-in to do this? Is it because we're asking them to do so much in covering, now it's additional patients, additional workflow? How do you justify being able to do that?
I'll take a first shot at that. You know, so the second part of that is how do you get adoption of telehealth? And that's been an easier conversation now than it was 10 years ago, I'll say that. You know, you always hear telehealth is a disruptive technology, and it is disruptive. But what you really need to spend time on in your disruption is people and process. And just, you know, like when a bone breaks, when it heals back stronger than before. If you use disruptive technology and disruptive forces, you need to go back and do the repair work after you've implemented the program. And with that repair work, you're then able to solve a lot of workflow problems. And that constant looking at it is really important. You know, I'll say that we have the opportunity with virtual nursing. You know, we have 2 things driving healthcare right now are workflow redesign and virtual care. We can bring those together with virtual nursing, but getting in front of that and how we implement and lead virtual nursing will be really important. And then finally, on the buy-in from the physicians, I think a lot of it is, you know, can you unload their night work, which is highly correlated with burnout, and, you know, can unload them and allow them to sleep. And then the other great thing about telehealth is there's tons of timestamp data. There's also risk-adjusted data, so you can really look at outcomes in depth and try to highlight areas to attack and to get better in.
The other part of your question was around education and getting it started. So does anyone want to address that piece? Or I will throw out that the American Association of Critical Care Nurses offers a consensus statement for telecritical care nursing that would help with a startup and getting those things just established. So I'll put that there for you, and then.
Yeah, I was going to say, for most of us that started this journey 10, 15 years ago, at the time, you had to identify the true believers or the early believers, the early adopters, so to speak. I think one thing we found, that was one variable we found that was really important. You had to have people who wanted to practice that way. If you dragged people who did not think it was a viable way of doing things and were not interested, it would come across in the interactions and in the outcomes and in the performance. And the other variable was you had to have experienced people. So experienced meaning they weren't just fresh out of school, right? So our first set of nurses in our center had 5, 6, 10 years of bedside critical care nursing experience. Same thing with our providers. You had to have had several years of experience. So you need to know what you're doing so that when I give you the data, then you can make the appropriate decisions. And you can do that back to back to back for multiple patients. So I think that level of experience is critical because now you're having responsibility for a much broader pool of patients. And secondly, that interest. Not everyone is cut out to do every type of medicine or every type of nursing. Interest varies. So if you don't want to be here, then I don't want you here because the experience is going to be bad for the people around you, for the patients on the other end, and for the nurses and doctors at the bedside.
Yep. Dr. Worthy?
So I go back to people, processes, and technology. Do not start with the technology, start with the people. Because there's real people, on the other side of the screen. If you're starting a program, bring those people on site so that your doctors can meet the doctors that will be helping them. Same with the nurses. It still should be a partnership, should be a relationship. So if you're trying to change minds, start with people. It's kind of like, you don't change too many minds with data, but stories. If you get their heart, you'll get their head. It's kind of that same mentality. So I would say if you're trying to get people to understand it, connect them to people that have used it, connect them to people that are doing that, let them see that we're all trying to pull the same way, and then go to the process. And the technology, it's just a toy, as I call it. It's one other way of delivering. It's just a method. It's still about people. So I think that would be my advice.
Yeah, I totally agree with that, Dr. Worthy. It's about the partnership, and only when you establish a partnership.
Can you pop his mic on? No. You can go
Okay.
there it
Only
is.
when you establish a really close partnership between your tele-ICU team and your bedside team can you achieve the sort of length of stay and mortality reductions and other best practice improvements that the tele-ICU has shown to be possible. It's all about the partnership and those relationships.
The other thing I would add for those of you who are looking to get started or who are already established and need a resource is that the ATA offers the Acute and Critical Care SIG, Special Interest Group. We are a community that we have a monthly meeting 10 months of the year. We have a community where we can ask questions back and forth and share resources, and we invite you to join that and join us with that. As one of the co-chairs, I invite you to come with us, and you can learn all sorts of things and then share your best practices as well. So we have about a minute left, minute and a half. What other questions are there? Yes, in the back. She's bringing you a mic. It's 50. Well, we had 50.
As you forge forward with this concept, have you considered or do you have any plans to work with the licensing agencies? Because I think there can be some issues with potentially getting in trouble or something along those lines.
There are the compact states that have, I think there's 38 nursing states that have the compact that they share licenses among, and then there's also a compact for advanced practice providers as well as a compact for physicians. And so a lot of that work has already been done. Would anyone else like to address that?
It's made the process easier to get licenses across state lines.
Yeah.
You still need to be licensed in every state, but with these compacts, and it makes it easier to get the licenses done.
I saw one more hand up back there. Maybe it was the same question. There, she's bringing you the mic.
A question just regarding tele-ICU billing. In most cases, what we understand are people are not billing for tele-ICU services for urban facilities. because of the challenges associated with that. Is the juice worth the squeeze? I'm wondering if any of you bill for tele-ICU services or not, or just consider it an extension of the in-person service.
Yeah, the public health emergency has sort of opened up opportunities for billing that didn't exist, pre-pandemic. We've considered that, but as a general sort of suggestion to anyone considering starting their own tele-ICU service, the thing to remember is you don't want any billing that you're doing to at all interfere with any billing being done by the bedside. So I would say that, is it possible? Yes, but you also just want to make sure that the presence of your billing doesn't interfere with the work or professional billing fees being done by anyone at the bedside, because that has the potential to really disrupt the productivity and the positive benefits of the tele-ICU, because it has a potential to affect that sort of partnership relationship.
I think the vast majority of programs are not billing, and the PHE is ending very soon. So it's an ongoing challenge, but I think it's a testament to the value of tele-ICU that programs have continued to grow even pre-pandemic, because their value was demonstrated. And post-pandemic, we're no longer hearing, can you deliver care through telemedicine in the ICU? It now becomes a matter of how much more can we do. And the other point I was going to make about this is reimbursement continues to drop. Even if they let us start billing easily tomorrow, just in January, reimbursement for bedside critical care was effectively cut in half by CMS. Yeah, so if we keep chasing that, it's just going to keep ratcheting down. So I think the more we focus on the value we bring in reducing cost and all of that, the question about how much revenue you bring in becomes less material.
Thank you all for coming today. We were at our time. I appreciate all of you for being here, and I appreciate our wonderful panel. So thank you very much.